I'll just make a few introductions first. So welcome on behalf of the SIPP and Smart Tech to this webinar. Dr. Hira, thank you for this opportunity for training. This is an educational initiative for training candidates who are interested in pain medicine. And this week's topic, this free webinar, the theme is on neuromodulation. For our delegates who are attending, Dr. Hira he works with the NHS. He's a veteran in neuromodulation, and he has a very strong CV. He has worked in neuromodulation programs before. I have worked with him when he was in India, and he's a very down-to-earth and very erudite, very learned human being, and a nice person. I think we are in for a treat. Let's hope a lot of our basic questions can be answered with this. So it's all yours, Dr. Hira. You may please start. And thanks to the SIPP and Smart Tech for giving us a platform to organize this event.
Thank you, Mahesh. I'll just get my screen shared. My screen sharing seems to be disabled, Mahesh.
Could you check now, please? Can you check, please, now?
Yeah, let me try that. Can you see the presentation front page, Mahesh?
So right now I can just see a blank screen.
Okay. Stop sharing. Okay. Sorry, Mahesh, just I'm not getting this. Yep. Can you see
Yes.
presentation come up?
Yes, you're visible. You're able to see the presentation, and you're audible also.
Brilliant. Let me just. Okay. Anyway. I'm Dr. Hirachand. Anyway, now one of the highlights of my career in pain medicine has been when I was invited as a faculty to the IISP multidisciplinary budding pain physicians training program arranged by IISP in Mumbai, and I had the joy of being a co-faculty with Dr. Srinivasa Raja, whose books I had read during my training many years ago, and it was a real pleasure. One of the themes that came up among that bunch of budding pain physicians, who were actually some of them were reasonably experienced, was that spinal cord stimulation really drew a lot of excitement and focus with a real interest regarding the topic in that particular lecture. Clearly, it was viewed as a panacea for all chronic pain patients. Now, when you say panacea, I really mean it, because that's precisely what this therapy can be, but I hasten to add a small group of patients. Okay. Now, I'm just about to. reshare the screen again because I'm not seeing the presentation myself on. Can you see my presentation now, Mahesh?
No, we can't see your presentation right now. Yes, we can see your presentation now.
And can you see me at the same time?
Yes, we can see you. Yes.
Yeah, we can. Okay. Now I've got a view of just my presentation. So anyway, I will go ahead. Okay. So I was saying that yes, spinal cord stimulation as a panacea, as a final common treatment opportunity for many of our chronic pain patients. And it can be, however, there are a few caveats, and we need to understand that. We need to understand the therapy to understand why I say that particular reservations. But spinal cord stimulation is commonly a final pathway for our patients when they've exhausted many other avenues. In today's presentation, what I intend to do is discuss about neuromodulation introduction itself, a bit of selection and indication, and I tend to always focus a lot on selection, but I will try to just rein in myself a little bit because I think that's the most crucial part of this whole patient's journey of accessing this therapy. We'll talk a little bit of mechanisms, a bit of electrophysics and the neurochemistry around it. We'll discuss a little about challenges of conventional tonic spinal cord stimulation. We'll probably talk a bit more about what this means. Technological advances and solutions. I'm going to touch on evidence base, not going into detail or bore you with a lot of papers and studies. I'll try to focus a bit more on technicalities and understanding the principles of spinal cord stimulation. And we'll touch upon the final new frontier of spinal cord stimulation therapy that has been a bit topical in the recent medical news. Neuromodulation or spinal cord stimulation has been going on for a reasonably long duration, well over 50 years in humans. Of course, neurostimulation predates that. There's a lot of literature going back as early as the early first decade of 20th century, even earlier than that, 2 or 3 centuries ago, where electrical stimulation was used. Of course, they're using more biological electrical stimulation, like stinging or electric fish or things along those lines. But more recently, the deep brain stimulation started sometime in the first decade of the 20th century. But spinal cord stimulation in its current form that we are currently practicing really took its birth in 1969 with that paper published in Anesthesia and Analgesia in 1967. There was a preliminary investigation. Subsequently, the first paper of human SCS happened in 1969. There have been multiple progressions since then, and I'm sure you'll understand the last 2 decades, change in technology, electronics, communication, and the computer chips has been remarkable. Change in technology in battery also has been remarkable, and this all has fed into the spinal cord stimulation or neuromodulation therapy reign in the last one or 2 decades. Now, electricity as a treatment is gaining prominence. I want to specify here when I say electricity, when you say neuromodulation, basics, neuromodulation can be anything. Neuromodulation is basically defined as something that will modulate the nerves. And this can be done by electricity, this can be done by chemicals, this can be done, even a gabapentinoid therapy that you initiate on patients is also a neuromodulation treatment. However, when we say neuromodulation in interventional pain medicine, we're usually talking about spinal cord stimulation and talking about intrathecal drug delivery systems. Again, I would like to leave the chemical neuromodulation aside because that's a completely different topic. And moreover, the preponderance of literature and the practice has moved from chemical neuromodulation over to electrical neuromodulation.
Dr. Hira,
and applications
Dr.
of
Hira,
electricity as a treatment.
Yeah, Dr. Hira, I'm sorry to interrupt. Your slides aren't moving actually, and we need you to request you to make your slides full screen because we are just able to see the layout, the slide sorter layout. We are not able to see the.
Okay, I'm good. So,
we'll have the full screen view. Yes, please.
So
Yes.
did some of the slides move at all?
No, none of them have moved so far. But I think I get a
None of them
sense
moved
of
so far.
where you're. I get a sense of where you're moving with this one because you started with the introduction and then you went to the overview. I think you must be on to the fourth slide by now because you've finished history.
Yeah, I know, but did you see the slides move at any point at all?
No, 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 not yet, not yet.
No, not at all. Okay. So I'm going to stop this sharing and try again.
This is Murphy's law. We are talking about spinal cord stimulation and we are having a problem with moving slides. Huh?
Are you seeing that now?
Not yet, actually.
You
So do you
see,
want to go on to the slideshow and try it from there? If you want to click on the slideshow and start slideshow or use some alternate.
I've done, yeah, I've shared a slideshow.
So that line isn't working. So if you could just go on to the toolbar, the ribbon bar up there and just see this.
Okay. This is not.
So if you go to
Mahesh,
the
can I
toolbar on
just
top,
come off the browser? I'm going to log out. I'm going to
okay,
join back in,
sure.
hopefully with the app directly from Zoom rather than through a browser.
Let's do that. Let's
I'll
do
be
that.
back in 20, 30 seconds.
Appreciate it. Yes, yes. Thanks. Thanks for bearing with us. We'll try and troubleshoot live. So in the meanwhile, these are some of the activities that the SIPP and Smart Pain Tech is organizing. For those who have tried neuromodulation, maybe this is another lesson in patience because you get the leads in place, everything looks good, and then you're not getting the right stimulation. So you keep playing around, and I think this teaches us some patience. And as I said, it's Murphy's law because we are supposed to have a talk on technology, and this is where technology can be challenging for us. For those who are attending, the next month's webinar is going to be on endoscopic disc procedures, and the month after that is going to be on cancer pain. So please watch this space. We have not put that in the upcoming events yet. And when it's out there, you will see it on our page, and SIPP and Smart Paintech will put up those notices then. Thanks for being with us. Dr. Hira has joined us back. Fingers crossed.
Okay, can you hear me?
Yes, we can hear you now.
Perfect. I will start sharing my screen. It was not allowing me to earlier.
We can see your screen.
Can you see that?
Yes, we can.
Perfect. I think this, and how is that?
That's much better. So I was just saying that this is just like neuromodulation when you get the leads in the right spot, but you're not able to get the right stimulation, and then you struggle a bit. So we found something now. Thanks, Prof. And
so I'm going to start changing the slides. Tell me, can you see that?
Yes, they are visible as
well. It is all moving. Correct. Okay.
Yes.
That's brilliant. So we're talking about neuromodulation as a panacea of chronic pain treatment, and certainly feels like you can achieve that result. However, there are some caveats for you to understand. As an overview, we're going to look into different aspects of this. I've sort of discussed this a little earlier, but I'm going to focus a lot on the technical aspect and focus a lot on the tonic SCS lead placements. We'll talk about some new developments as we go along. We talked about initial electricity being used as a treatment for a long time, but the initial human SCS therapy per se started in 1969 with that seminal paper published by Shelley in 1969, with a lot of advantages that have got improvements and innovations that have happened in the spinal cord stimulation realms in electronics, chip development, battery technology has meant a significant change in neuromodulation as a treatment in the last few years. So after having zooming through those first few slides, we know that electricity is used as a treatment in multiple avenues, but neuromodulation per se, for chronic pain perspective, can be quite varied. When I say neuromodulation, this chemical neuromodulation as well, including a gabapentinoid therapy, is a neuromodulator therapy. Now, we know electricity can be used in various other realms of medicine, and we are aware of the cardiac applications of it. We are aware of neuro applications of it. There's transcranial stimulation there. We also transcutaneous applications, cosmetic applications, and something that I will probably need, including hair treatment, and that was as way back as 1920s. Now, pain treatment always has been a continuum. So you start less aggressive, less invasive, cheaper versions, progressing on to the continuum of treatment, including neuroablation treatments. Earlier, to be likely lower continuum, neurostimulation, intrathecal therapy tend to be higher up. But as time has gone on, we realize that neuroablation is not a long-term viable solution unless it's end of life. In which case the neurostimulation is slowly coming down the ladder, which means people are accessing it earlier in the continuum of treatment as opposed to later. The beauty of neurostimulation is basically it is testable. It is completely reversible. It is non-destructive. And if at all you need to bail out for whatever reason, then there is no limitations for future therapy. There was, in a way, some limitations when MRI incompatible equipment was in the market, but as time has gone on, more and more MRI compatible systems coming the way. Selection of a patient, of your patient is very important. Selection of patient. I'm not even talking about SCS. It's just selection of equipment is slightly easier part. Your patient is very key because once you implant something in a patient, you can get divorced, but you can't get rid of that patient. That patient is yours for life. Anytime the patient develops any problems whatsoever, completely distant, headaches coming from lumbar leads placement, you will get called 10 years later. So the understanding of this therapy in the general population is very, very low. Not in general population and the medical fraternity is very low. And there's a significant high chance of attributing the new symptom development with a potential link to the implanted neuromotor device that you do. We talk of selection. Now, I'm focusing a lot of patient selection first and foremost because aberrant opioid history, drug-seeking behavior, focus on heavy opiates, diversion history, they're all contraindications for you to consider neuromodulation as a treatment option. You need to make sure that whatever psychopathology is existing, every chronic pain patient of a long duration will have psychopathology as natural, but you need to distinguish primary psychopathology from secondary corroborating commensurate psychopathology that is as a result of chronic pain. And that does mean you have to ensure you have got an MDT team with yourself to actually try and distinguish that. Now, you need to understand the appropriate risks and benefits of spinal cord stimulation. So if at all the patient is not in an ability to understand this, if at all a patient is not in a capacity to manage a smartphone or a sophisticated phone, then you need to wonder whether that patient is the right candidate for your treatment, purely because if at all they can't manage an electronic device, and as time has gone on, many of the spinal cord stimulation treatments have become very, very sophisticated piece of electronics. And this means they will not utilize that particular kit that you're implanting in them sufficiently well enough to be meaningful for them. Now, the disease itself, there are certain illnesses or diseases or certain conditions of neuropathic pain that are more likely to be responsive to your treatment. Certainly, it's radicular pain, nerve pain, complex regional pain syndrome, neuropathy pains. Okay, now here angina pectoris is mentioned, but remember we are focusing today on predominantly spinal pain. Okay, and then of course there are certain spinal cord injury pain, the neuropathic pain following that doesn't tend to respond very well. Post-stroke pain does not respond very well. Brachial plexus avulsion doesn't respond very well because this is commonly thought the injury happens avulsion at the root entry zone rather than in the nerve trunks of the brachial plexus. And that root entry zone brachial plexus avulsions don't tend to respond very well. Okay. There are certain phantom pains, again, uncertain origin, but worth trying if at all your patient is suitable. Axial back pain probably doesn't improve very much, and maintaining and sustaining any relief you get for axial back pain is usually a challenge. We'll talk about the electrophysiology around it as we go ahead in the presentation. Now, principles of screening. You need to identify and accurately select a patient. Your patient has to be commensurate, appropriate pathology, no psychopathology. Even if there is psychopathology, it's secondary to your pain illness. You need to ensure that that's the case. Your goal should be set. What is your target you're trying to achieve? 100% pain improvement is unachievable. We have managed to achieve it, and if there is one therapy that we can say in chronic pain, there are just a few handfuls you can confidently say, I can give you 100% pain relief, and this is one of them. The goals, have to be on a case-by-case basis. You need to identify with that particular patient, what are you trying to achieve in you, and this is the goal. Beyond that is additional gains. Okay, and you should try and ensure that your spinal cord stimulation trial that you will initiate, because as I said, remember, this is one treatment where you can undertake a trial before you can institute the therapy, and which means if your trial can be as close to your permanent implant, that will be advisable. Okay, and remember, spinal cord stimulation is only a one cog of your treatment plan. The other cogs of your treatment plan of reasonable small dose of opiates, adjunct antineuropathic medications, ongoing psychological treatments, physiotherapy and rehab should be going hand in hand with frequent reviews. Now, the primary target when you're trying to do neuromodulation, that is electricity neuromodulation, spinal cord stimulation, is you want to map your spinal cord stimulator achieved paresthesia overlap the target pain area. Okay, and that's crucial. If you can't achieve your pain area mapped by the paresthesia, you will not get a benefit. Now, this is a scenario here on the screen slide where the pain area is mid-shin onwards. Your paresthesia coverage is much, much higher. However, you can also argue whether a part of the pain is not covered along the posterior part of the leg by your paresthesia. However, if 80% of your pain area is covered with paresthesia, generally you tend to get a good benefit. So the more proportion of your pain area is covered, the better the benefit. And over time, when therapy is instituted, we tend to notice that the pain map shrinks, and whatever 20% pain area is remaining, even that tends to regress over time. The purpose of spinal cord stimulation, also traditionally called dorsal column stimulation, is you're stimulating the dorsal column of the spinal cord by placing an epidural lead in the posterior epidural space. The epidural lead commonly now has got multiple contacts for you to utilize, where you can map the electrical field in a specific pattern. And its dorsal column, remember, if at all this lead slips further a little, few millimeters, a typical side to side, left to right canal diameter in a thoracic spine is generally varying between 13 to 19 millimeters. So one side, you have got just about 7 to 9 millimeters. So if your lead is a few millimeters off target, then you might not get the right benefit. If your lead is sits slightly in the paravertebral gutters, you're going to get more root stimulation rather than spinal cord dorsal column stimulation. Root stimulation can be unpleasant paresthesia. So the focus is dorsal column stimulation. And what you're trying to achieve is a lead placed outside in the epidural space. You're using current through this, creating an electrical field around your lead. That current will basically be this is a cylindrical lead, which means you're going to have a current flowing around it, okay? And which means that current has to penetrate through the dura, through the CSF, into the dorsal column of the spinal cord. Cylindrical leads, remember, there's some wasted electricity because you're also stimulating the laminae and the ligaments of spinal canal. The real interest is for you the dorsal columns, okay, not the root entry zone of the dorsal root. When you place a lead in the dorsal epidural space, you are creating electrical field around it. Different impedances of different tissue will mean different transmission rate. The impedance of CSF is much less, which means you can see electricity traveling much further in the CSF. Once it hits the spinal cord, there'll be some impedance of the interface, and then you'll get some penetration of the electric field into the spinal or dorsal columns as well. And that's what you want to target. When you actually get current into the dorsal columns, that's when you will get the stimulation of the neural fibers or the axons that will lead to paresthesia by antidromic transmission along the axons cranially, okay? By the dromic transmission, and the antidromic will be distally. Now, these are the different impedances or conductivity of the different tissue, and that's the reason you will find that while we postulate that the lead is placed there, you will get an electric field spreading across into the dorsal that is more likely to be, you're going to have electric field that comes a shorter distance posteriorly because of lots of the laminae, bone, and ligaments. Here you'd get it in the CSF, you'll find that you would probably go much higher, you go forwards. In the structure will be smaller there. Okay, the penetration won't be as much as in the CSF. Again, it'll be much further out there. It'll be this penetration here will be smaller. So that will be your electrical field. Now, SCS placement involves, just give me 1 minute, I'll close the door. Thank you. Now, SCS placement involves, and I must emphasize, selection of your patient. Again, selection of patient. The kit selection is the easy part, okay? And then you need to prepare, okay? And you got to prepare this patient. And if that means there are certain centers that will actually make sure this patient goes through a pain management program before they're committed to a spinal cord stimulator, with the intention of making sure they optimize all possible pain coping skills to achieve the best result. So remember, I said spinal cord stimulation is not the whole and only treatment, while it is a panacea as it is thought by many, but you need to be in conjunction with other treatments to go alongside it. You choose your equipment, you make sure that all the risks are explained to the patient. The most important ones of these revision surgery rates are 1 in 4. Failure rates can be anywhere between 1 in 5 to 1 in 10. Infection rate generally vary between about 5% up to 20%, depending on different published series. And as I said, with great power comes great responsibility, because if at all you don't take that responsibility seriously, then you're going to have headaches for a long, long time to come. Now, over here, what you will find is that we're talking the technical aspects of your spinal cord stimulation. You'll always find these patients tend to be done in prone position. So of course, you've selected your patient, you've prepared them, you've educated them, you've consented them, you've chosen the right pathology, the right patient, if at all they've got psychopathology that's been looked at, addressed, and treated before they get this far. Over here, most patients are prone, more commonly than prone. Sometimes patients can't lie prone, in which case you might choose alternative avenues. There's one particular occasion where I was doing a spinal cord stimulation with one patient, and we placed the leads, and we're getting stimulation in the leg, but it was uncomfortable, and we could not manage to get. So we stopped the stimulation. So when I say stimulation, before actually jumping there. So what I'm showing here picture is a prone position. There are epidural leads placed, epidural needles placed. There's leads placed through them. At this end, you connect it to a trial stimulator, external stimulator. So there's a box that sits outside, and you can use that to pass current. These are all trial stimulation on the table. At the time, you're trying to map paresthesia down the legs or the area of pain to map. Okay. Now, when you're trying to do that, this patient was saying that he's feeling it in the leg, but could not, but continues to have pain. It's hurting. We stopped the current. We disconnected the trial stimulator leads, and he said his leg is still hurting. And what exactly was happening was we actually abandoned it. Once we put him in prone, he had spinal segmental instability, just causing radiculopathy. And that is not going to improve because it's a mechanical radiculopathy by instability, and that is not going to be improved by spinal cord stimulation. Once we got him on supine, sat up the next day on the ward, when we are seeing him again, his leg pain was better because now he was in a more conducive position as opposed to a prone position, which was not conducive for him. So we didn't. So that was a mechanical radiculopathy rather than chemical or irritation, neurogenic irritation or neurogenic inflammation radiculopathy. So over here, so when we start off, we always place an epidural. The key part of placing an epidural here is the angle. If you notice the angle, it is very shallow. The more shallow the angle, more easily the leads will pass through. If it will go more vertical, the lead has to take a right sharp angle. When you can access the epidural, it has to right sharp bend, and it will be going cleanly into the spinal canal. Now, anytime you want to maneuver, you've got to steer these leads into position. Okay, this lead is a little far out in the lateral canal. You need to get it steered back to the midline. Okay, and we can only steer this if at all there's a nice line across here from the lead, a shallow angle. If at all is a right angle, any twisting maneuvers you do at this end will not get transmitted across to the tip, which has got a slight bend and a curve on it, if you notice. So you can only steer it if at all you've got a nice shallow angle for one, ease of placing the lead, second, ease of steering the lead. Your epidural axis, if you notice these two needles are placed, and you can see a bevel on those epidural needles. Can you see that bevel? The bevel on this needle is facing medially because I don't want the lead to go into the paravertebral gutter. And the other needle, you can see the bevel is facing again medially away. Can you see that? And this lead again trying to keep it to the midline. Okay, trying to get it towards the midline, just midline of paramedian is what you anticipate to do. Thorough asepsis, just like any other implant, knee replacement, knee orthopedic implant, vascular implant, very similar to that. Antibody prophylaxis, generally I recommend you follow what your institute protocol is for orthopedic surgery or vascular graft surgery. Once you have placed this lead and you have connected a trial stimulation, external stimulator, you get paresthesia mapped into the area of pain into the legs. Then you would be withdrawing these needles. You would anchor these leads. Remember, the needles are anchored in the spine to the deep fascia. So your fixed point on your system is on the deep fascia. You have a redundant SCS lead that traverses from the deep fascia through the ligaments, through the interlaminar space, along in the epidural space. So if at all there's movement of the spine, the anchor point is here in the deep fascia at this level. You still have a redundant area of SCS lead that can slide forward and backward and side to side depending on the spine movement, whether it's rotational or bending and straightening. So the lead will be moving slightly forward and backward, side to side, depending on the movement, because the anchoring happens at the deep fascia level, and there is no means of ensuring that the lead will take hold in the epidural space. There's no means of doing that. If you do that, then there's a risk of adhesions there, and if at all you need to explant that lead for whatever reason, then there's a difficulty in getting it out. What you also need to understand is what I'm showing you is all percutaneous cylindrical leads as like wires. However, neurosurgeons will also do a similar operation where they will dissect down to the laminae, they will do minor phlebotomy, minor laminotomy if required, and they will slip a pedal lead. A pedal lead will basically be flat, will have the electric contacts in that with the wires coming out from the other end, and they can be a range of contacts. They're just linear contacts on the electrode. There could be two columns of them. There could be 3 columns of them, depending on what they choose and the width they would like to choose. And this is just slip render. That tends to be a lot more stable, remember, because it's a flat surface. Second is a lot more electricity wise. It saves electricity. When I say that, what I mean is the back part of the leads are insulated. And so there's no current actually that is actually stimulating the laminae and the ligaments posteriorly. All the current is used in stimulating an electric field anteriorly, which means they're more efficient in using the current of your implanted battery. The key part of making sure lead migration can be as high as 15 to 25% in the first few months following implantation. And anchoring techniques of your lead in the deep fascia are crucial. Second, lead failure and fractures are very common at junction points where there is a loop at the fascia puncture level, at the laminae puncture site. Because with movement, if at all you see that laminae, that particular interlaminar space is actually shrinking and moving, it could actually be compressing on that particular lead frequently, and we get fatigue fractures commonly at where the entry point of the epidural space is, but the most common actually is where the anchor is at the deep fascia. And that is the reason why the anchors with a nose, so the lead goes through that and they're anchoring this to the deep fascia. These are anchored to the deep fascia, and this nose actually dives through the deep fascia into the tissue, so giving it some protection. It's just like your mobile charger point. The weakest link is actually very connected to the foam, or the weakest link is where the USB port connects to the power point, where it tends to get bent frequently and they get fatigue fractures. And very similarly, it's these bend points are the ones that are the reason for fatigue failure or fractures of the lead. Pulse generator is commonly implanted from once the lead's there, it's buried. This leads are buried, a connector is put through, that is tunneled across, and you can either implant it as a single incision battery in the back. You can, the next common one, the most common is actually the abdomen, but this is rarely done by some practitioners. Other one is you tunnel the wires subcutaneously, you get a subcutaneous pocket in the buttock, superlateral quadrant of the buttock. Apologies for that. Superlateral quadrant of the buttock is where you implant the battery, and the wires are connected up to them, and you got to make sure that they're well connected and secure, because any liquid ingress into the system will include increased corrosion and the equipment failure rate in the future. They all have got self-sealing screw caps, head caps, and a good boots on where the leads enter into this. There were little boots like this where you can tie strain relief loops around silicone that sits and seals it quite nicely. The important part is when these leads are placed, as I said, they have to be posterior epidural. It's not common, if at all, I just stress this particular lead. This lead, we can bring it back to the center and set it next year. But the important part is you need to check a lateral film, because in a lateral film, this leads are coming to anterior epidural space, vertebral body, posterior epidural space, anterior epidural space, posterior epidural space, and it is in the posterior epidural space. If at all you got a lead at any point just approaching the lateral part of the canal, it might actually going around the thecal sac, and you might get this lead in AP view, AP fluoroscopy, sitting very close to and parallel to your first lead. But when you check posteriorly, you will see that the first lead is sitting there. The second lead actually has gone around the thecal sac, come to the front, and is sitting in front of the thecal sac, and that will not be beneficial. Trial of spinal cord stimulation. There's different regimes that people follow. You can do an on-table trial for a few minutes. There are occasions when you've got a very focal pathology of neuropathic pain, and you get the paresthesia mapping perfectly, and instantly they say that my pain is gone. I haven't slept properly for 5 years. This pain, I can't feel that pain. This is so pleasant. Now, there are some pertinent characteristics of the patient, characteristics of the disease, and the response you get on trial. You might choose to go for a full implant and go for an IPG placement. But commonly you find that some centers have got a regime where they will do a trial for a day, 2 days, or a week. Some countries, for insurance and funding purposes, have got to do a 2 to 3 week trial before they will fund the expensive battery. Okay, so a lot of the trial duration will depend on local practice, local funding arrangements, or determined by the other confounding factors in instituting the therapy. Only after the trial, you go for a permanent spinal cord stimulator, which is basically an epidural placed lead anchored to the deep fascia, interlaminar access, leads positioned at the appropriate level. The target of where you place the lead will depend on pain map, and that can vary depending on, if it all mainly foot, you want to be around T10, 11, 12. If it all is going to be predominantly proximal thigh, you look at T9, 10, 11. That's the sort of area you would want to place the leads, because those neural fibers, as they're traversing from the peripheral tissues through the radicals into the spinal cord, will be taking 1 or 2 segments to get into the dorsal columns before. So if at all you go targeting L2, 3, L4, or sort of a dermatomes, you can't place it at L3, 4, because those L3, 4 fibers are still sitting in the nerve root or just the periphery part of the spinal cord. Okay, and that is not accessible. So that will take 2 or 3 segments for it to actually cross and get to its final pathway. That means that's the reason your lead placements are done more proximally compared to more distally. The whole idea of doing spinal cord stimulation, that's your spinal canal, your dorsal horns, spinal cord, dorsal root entry zone, is the epidural space. You place the leads, you pass a current through them, you're creating electrical field that penetrates through the tissue, doing dorsal column stimulation. That's the whole idea of trying to achieve your treatment. Now, looking at the electrophysiology, what happens when you use, be it a TENS machine, because this is a picture from a TENS machine, that's skin. So be it epidurally placed lead or be it a TENS machine lead, what you will find is that your anode is a positive, cathode is a negative end. And because cathode is a negative, it causes accumulation of positive at the exons. You'll find it's at the positive at that end, which means there's depolarization happening at the cathode. So our understanding commonly is that anode causes spinal cord stimulation. No, it's a cathode that causes depolarization. Anode is there just for completing the circuit. So cathode causes depolarization. You need to understand that. And you can change the parameters there in terms of polarity. So polarity can be changed. There can be plus and minus. That's what you can do in a spinal cord stimulator. You can change the frequency of current you're using. Commonly in a conventional spinal cord stimulator frequencies, you're looking at 20 to 60, maybe even up to 100 sometimes. But 20 to 60 is a common range for frequency used for spinal cord stimulator. You change the amplitude, like the volume button of your music system, and the pulse width is how each pulse of the stimulation is given how much longer. So more the pulse width, more the current, more the penetration. of your electrical field into the neuron. More the pulse width, more the energy consumed of your battery. So all these will determine how long your battery will last. What we do know is we need to cause depolarization at the cathode end. The electrical stimulation happens at the cathode end. The anode can be utilized for helping steer this current field. And when I say that, the next slide, you will see that that's your dorsal horns, dorsal columns, that's your spinal cord. Those are electrodes, 2 electrodes placed parallel to each other. In reality, there are 2 electrodes with 8 contacts at each levels. So if at all you do the trial on the table and you put a contact at the middle of the lead, and when you wake them up and they're sitting in a chair, you're trying to program them for stimulation, you might find that your 4th and 5th contact on these particular leads are not working for you. Your higher ones may work or lower ones may work because the lead is slightly moved up or down in the spinal canal since your prone positioning on the table, because anchoring happens up deep fascia, remember. So if you put an anode cathode on side to side rather than anode on the same lead, anode cathode, you put an anode on the contralateral lead and a cathode there, then what you're doing, you're steering this electric current further away to the left, rather than if at all you do this cathode, okay, in the same electrode, if you do cathode, anode guarding a cathode, you'll find that you get more penetration with the anodes on either side. The penetration electric field is a bit more further into the spinal cord. Okay, so if at all you find that with that you're not getting the targeted stimulation, you might have to just map it and try a side-to-side anode cathode combination. More anodes putting in a bit more cathodes. So based on the combination, you can steer the electrical field slightly to the right, to the left, depending on where you put the cathode and how you lay them out. 2 anodes on this side, okay, 1 cathode. You'll find that penetration is slightly worse and steer a bit further. So this is how you do electrical field steering to target your paresthesia. You might have to give slightly different sitting posture, 1 program, because the leads tend to just slip a little bit, 1 program to cover the foot or the leg below the knee. And then if at all they're standing and working and doing something, they might have another program with a slightly different configuration, which might give them a better coverage for the same area of pain. Now, how does all this work, though? You've placed a lead in the epidural space, you're passing current through, you're doing a sophisticated technique, you've committed to, so how does it all work? It is all thought to be a gate control theory. And of course, that has gone back way back in 1965. But your CEF pain fibers are the ones that are going to do a projection neuron that cause activation of pain sensation. There always is some inhibitory interneurons as well, but this is not overriding your pain sensation. Your pain sensation is overriding. However, we use A beta, A alpha fibers for us that we use in the spinal cord stimulation to have pleasant paresthesia. So when you do spinal cord stimulation, you're creating pleasant paresthesia along the A beta fibers that will also stimulate the inhibitory interneuron that will have a reduced or weak activation. Reduced or weak activation, remember, we are not achieving 100% relief. We're achieving significant step improvement in pain. And that's what you're targeting for, because we never promise 100%. We might, with 1 therapy, we might achieve it, but we can't always guarantee it. The neurochemical mechanisms, it can be reasonably complex. There are excitatory pathways, there are inhibitory pathways, and at the dorsal horn level, you got the A afferents and the C afferents, second order neurons. So at all these levels, you can have antidromic with the stimulation on the dorsal columns, antidromic communication and pleasant paresthesia, replacing the pain area. It can cause hyperpolarization and blockage of the design. It can stimulate interneurons and cause neurotransmitters. So the chemicals involved here will be GABA inhibitor interneurons, serotonin, norepinephrine, adenosine. Of course, we got other modulation of wide dynamic range neurons. And these are basically neurons that we see in, I'm just going to go through. In the subsequent slides, I'll show you some pictures of that. But you've got lots of reserve neurons that sit in the spinal cord. We don't use all the neurons that we are born with. And these can get recruited for increasing the pain map, increasing sensitivity or lowering threshold for pain. And it is about these modulation of wide dynamic neurons that is involved in also effect of spinal cord stimulator. And what we have seen chemically is that we generally see an increase in the inhibitory neurotransmitters and a decrease in the stimulating neurotransmitters in the spinal cord in the dorsal column. Now, complications are a part and parcel of spinal cord therapy, and the most common ones are the lead complications, or either connection breakage, hardware malfunction, battery failure, and these can be quite common. And a common number that we usually report to patients before they're consenting is there's a 1 in 4 chance that they will need a revision surgery. Okay, and on occasions there's a 1 in 10 chance that they will need not more than one revision surgery to achieve optimal pain relief. The biological complications, of course, we would know, CSF hygroma, CSF leaks, dural punctures, infection, erosion of the IPG itself from where it is implanted. Then something like that is extremely rare. Paralysis and permanent neurological injury is extremely rare, more as a consequence of the other infection sort of and hematoma complications rather than the implant and the procedure itself. The rates of these complications vary quite significantly based on this case series that we're looking at. But the commonest one, infection, this is the big one purely because this is preventable. And this is, as I said, varies from 5 to about 10-15%. Some cities have gone as 15-20% as well. Okay, and there is some practice guidelines recommended by many of the regulatory authorities or different country pain societies to follow to make sure that patients tend to get less risk of infection. You generally will follow the exact precautions for surgical infection prevention that you would do for an implant like a knee replacement. Stimulation complications, some people will lose pain relief over time. This is more a long-term thing. There's one particular study which talked about complex regional pain syndrome. Over a 2-year period, they tend to develop tolerance to stimulation and they lose the benefit. However, in my experience, if at all your patient is selected and you have managed to reduce the wind up in that 2-year period, we have seen that the patients have returned to work, and any loss of therapy has meant they have still got manageable symptoms of CRPS without needing to resort to any other alternative therapy. Okay. Undesirable stimulation is also a possible risk. We'll talk about the electrophysiology of some of that going forward in our slides. Now, this is a section of your dorsal columns of the spinal cord. And as you see that if at all this is a column, a cut section of the dorsal column at the lower lumbar level, you would have only fibers for the sacral segments in there. As you go more and more cranial, you will have fibers coming from each level, starting laterally. And as you go higher and higher, each one will get pushed to the middle. Okay, so you can see over time that your pelvis and foot will be more medial, low back will be more proximal limb, will be further laterally. Okay, and your dermatomal map. This is a very schematic way of putting it, but you need to understand that we all like to think people in layers, but nothing is as full and clear-cut as this. But you will have a bit of merging between these, or blurred lines between these boundaries. But in principle, your deeper fibers, as you go cranial spinal cord, tend to be the foot, leg, and the more lateral fibers are more likely to be the back pain, and the more dermatomes closer to the level at which the transaction of the cord is being discussed. In addition, we also need to understand that at each of these dermatomes, what you've got is the neuronal representation. It's like the inverted homunculus on the brain, the cortex. We say our hands have got a bigger representation, our lips have got a bigger representation. The proximal arms don't have as much of a representation. So similarly, in the dorsal column of the spinal cord, and we have got representation of the quantity of nerves involved in the transmission or the axons in the dorsal columns. And you can find that a significant chunk of them tend to be L2, L1, L2, L3, L4 fibers. And the same dermatomal representation for the back will be smaller. So a lot of the same L1, L2, let's say L1 dermatomal fibers, a small number of those fibers will be representing the back itself, cutaneous and the myofascia around there. And the number of fibers from the L1 from other areas will be much, much larger. So if you took at each laminae in the dorsal column, if at all you talk about one particular dermatome, let's say that's L3, you'll find that the leg representation, anterior leg fibers are all in yellow, and they are much more numerous, okay, than the less sparse, scattered axial or back pain or low back fibers. So what this does translate into is you might get good stimulation into the back and the legs, but over the long period or long duration, you might get the back coverage dissipates. So they say it works well. I can get the paresthesia along the L2, L3, L4 dermatome, but I can't seem to feel that in my back. I can feel it in the legs. I can't feel in the back. So spinal cord stimulation, conventional, is always indicated for radicular pain in the leg. Axial back pain doesn't respond. Axial back pain, problems with axial back pain is predominantly mechanical. And if at all there's a component of neuropathic back pain, then spinal cord stimulation might help. However, maintaining coverage over a long duration is a real challenge. There are some solutions for that. We'll touch upon those as we go forward. But the principle of this being each dermatome has got predominantly leg fibers, lesser and sparser back fibers, which means sustaining contraction for back pain coverage, back pain, neuropathic pain coverage is challenging. Okay, so because they're fewer and less accessible. Okay, similarly, the extremities, focal foot pain, hand pain, the distal parts, neuropathy, peripheral neuropathy, severe neuropathy in the toes, in the foot itself, can be challenging to cover. If the neuropathy is covered progressing up to the knees, that's not a problem. The knees to the ankle can be well covered, but the fibers of the foot tend to get buried much deeper in the posterior dorsal columns, and you need much stronger currents to approach them and get them. If you do get them, it is also possible to get them by increasing the current parameters, current steering, and the lead combinations that you can manage to do. However, the problem then comes is to get penetration to that current, it becomes unpleasant paresthesia for the other fibers. So it becomes unpleasant at the knee and ankle to get stimulation to the foot, and then it is not sustainable purely because they say they can't use this therapy. It's uncomfortable for me to use. Remember, there's also postural variations we talked about. An example of that would be in a standing position. Your cord is sitting with a CSF rim around it. However, if the same person is lying down, what would happen then is the spinal cord is sinking in the spinal cord, and then the CSF cushion between your epidurally placed lead is much less, which means it becomes stronger because now the dorsal columns are getting closer to your leads. So your current penetration increases. So these postural variations have been managed by one is patient position dependent manual adjustments of the amplitudes. So they will, I'm going to lie down now, let me reduce the current, and then they go and lie down. And they need to get up now, let me increase the current, and then they stand up and move out. So this brings in a bit of adjustment and getting used to the kit spinal cord stimulator. And however, the industry in the current days of iPhones and gyroscopes and positional rotation of the screen, these systems have adopted and have driven sensor-driven adaptive stim, just like they sense when the patient's IPG is in a supine position, when they're in a standing position, and based on those change, there's adaptive stimulation current that is adapted within the parameters set by the programming, the industry-driven programmer, which means that there's some adaptation and you can get. Moreover, there's a further adaptation of the spinal cord stimulation and an offshoot of neuromodulation, which also has been particularly useful because here posture dependent variation won't happen. We'll talk a little bit about dorsal column stimulation as we go ahead in this presentation. Coming to dorsal column stimulation, as we touched upon it. Now, what we are doing here is we are not placing the lead on the dorsal column. We're actually trying to get a lead into the paravertebral gutters, into the neuroforamen, and get the lead through the foramen out. Obviously, this leads are thinner in their dimensions. They are flimsier, and they have got 4 contacts on them. Contact 1, 2, 3, 4. 4 contacts on them, and depending on which one gives you the best dorsal root ganglion stimulation. That's what you would utilize. Okay, and these leads placement are slightly different compared to a conventional lead placement that we talked about earlier. And the example of that is based on an epidural placed lead. Then you've got a sheath. It's a sheath on which this ball end lead is loaded, front loaded, which means you've got the sheath and you're loading the lead. On the screen, if you see, you've got a little ball like end there. Okay, and that stops the lead from going into the sheath itself. So you're front loading this lead into the sheath, and that front loaded sheath, you're passing through an epidural space, and the sheath has got a little hockey stick bend on it, and you're using that bend to try and navigate in the epidural space, and then you try and flip it around into the foramen. And the key here is this sheath has to sit posterior to the nerve root, because if it slips anterior to the nerve root, you'll get anterior root stimulation and motor switching. This has to stay posterior to the nerve root, and that's where the bend is useful to do. It can be particularly tricky to place in some places if there are adhesions or there's a tight foramen. Commonly, as in this picture, it is demonstrated, this is not the usual approach for doing that. The usual approach for placing dorsal column stimulation is you want to have a little bit of a leeway to be sitting in the epidural space so that it then slips into. So commonly you access the epidural space, you try and get it a bit more in the midline, this particular needle, you will get the sheath posterior in the epidural space, and once you approach this foramen, you use the bend to flip into the foramen and try and keep the bend such that you achieve this lead placement posterior to the dorsal root. So not like this picture, you tend to do, I tend to do one segment higher, but on occasions, if at all access is difficult, sometimes you end up doing it at the same level. Doing this at L5, S1 level can be particularly challenging purely because it's deep-seated. The angle of the theca is at right angles. And when you access your needle, you get the iliac crest coming in the way. When you do access the epidural space at that level, you're coming at a steep angle. And if you're coming at a steep angle, it's not shallow, which means your lead, because it's coming at a steep angle, rather than stay posterior thecal sac, can dip into the foramen and go anterior. So L5 S1 placements can be particularly challenging. I took the liberty of trying to do something unusual on this one, and I have placed about in 2 patients sacral hiatus lead. That gave me a good chance to stay posterior, and then drop the lead in. And I chose that purely because this patient had lumbar spinal surgery previously with radicular foot pain, and with epidural adhesions there, I do not want to place my needle at the decompression level. So I chose to go through sacral hiatus. It's not something I would commonly routinely recommend, purely because you place an implant very close to an unhygienic area, higher risk of infection. However, if at all you do that, risk of migration is much lower because you've got a good bony canal that has got no movement in it, and the implant is also in less movement area. Whenever you place implants in a highly mobile lower lumbar area, then you've got fatigue fractures, lead fractures, displacements, migrations that are very common. This is an example again of how the advantage of why I said that dorsal column stimulation postural variation won't happen, because there's a tight space, lead is very close by, very small rim of CSF that goes around into the dorsal root ganglion, which means postural variations don't happen. Second, for migration, what it tends to happen is when you place the lead, you retract the sheath, holding the lead in place, you retract the sheath. As you're retracting the sheath, what you then do is push through a lead and create an epidural, post-epidural space strain relief loop. So any movement that happen, this is tight, snug space, movements really accommodated for this strain relief loop that is sitting in the posterior epidural space of the lead. And then you're bringing in, anchoring it at the deep fascia level. You've got a deep fascia anchor, lead going to the epidural space, there's a strain relief loop sitting in the epidural space, and then the lead sitting in the foramen. So this is particularly useful for distal extremity pain, and moreover, it has got a huge role in truncal focal pains, groin pains, inguinal neuralgia, post-choreography pain, post-operative neuralgia of particular dermatomes, any particular dermatomes, focal area of pains along thoracic dermatome. Those are particularly useful. And we just a minute. And we did talk about reduced migration and epidural strain relief loop that gives it an advantage in terms of lesser postural variation. The study for this certainly showed that we get lesser power requirements, so battery size is smaller, and then reduced lead migration, but it is not unknown, it is still known. And this showed specific areas, specific dermatome stimulation to be particularly effective. Evidence-based for spinal cord stimulation, I think, has been well established and has been accepted as a treatment for neuropathic pain. There's these pain studies that fed into the NICE, which is a national organization in the United Kingdom to regulate and ration the appropriate evidence-based treatments in the NHS. So once it gets through NICE, which means there is a reasonable body of evidence to say that this is effective. However, as we've gone on and evolved this therapy, we noticed that over time, some patients' paresthesia gets intrusive, so they tend to not avoid using it, and then if they're not using it, it's not particularly useful. It's not recommended for them to be driving while they've got paresthesia, because if at all there's a road bump, sudden braking, and there's a sudden change in posture, you could have a sudden surge in stimulation, which might mean they inadvertently either press the brake or the accelerator. So that's the theory behind it. So it is not licensed for them to be driving when they've got a spinal cord stimulator in place. And then posture-dependent use also was noticed. They said in this posture, I don't tend to use it because it's very uncomfortable. And then also they limit current amplitude to get back and distal feet and hand coverage. I remember we said back coverage and the distance coverage is a problem. And again, another thing that came to fore over the last decade or so is that loss of efficacy over time. Just like you develop tolerance to opiates, there's a tendency noticed for tolerance to the effect of spinal cord stimulator. So you just lose efficacy over time. Paresthesia is covered, you're getting the right paresthesia, you don't feel it as much, it doesn't seem to be masking the pain as much as before. And that's when we started about a decade and a half ago, evolution of paresthesia-free spinal cord stimulator. There was a lot of skepticism on that in the initial few years regarding lack of evidence around it. However, one of the modes of this stimulation where you do paresthesia-free stimulation was called burst stimulation, where is different. So when we do spinal cord stimulator, remember I said earlier, we do a frequency of 20 to 60. In this particular scenario, you're giving bursts of stimulation at a frequency of 40 hertz. At 40 hertz frequency, in bursts of stimulation. And each of these burst stimulation is basically got 5 impulses or spikes at a frequency of 500 megahertz. 500 hertz, not megahertz. So at 500 hertz, you get 5 pulses, there's a gap. Get 5 pulses, there's a gap. And these pulses or bursts are given at a frequency of 40 hertz. Now, the idea of this is that it is paresthesia free, so you can give sub-threshold stimulation. And with each of this high frequency bursts, what you're trying to do is neurotransmitters like the GABA being cumulative because of the frequency at which you're giving it with the previous impulse. Next ones, there's an accumulation effect of it, which means you get slightly more prolonged benefit without actually. And because of accumulation effect, sub-threshold perception, the current spread is slightly wider, which means you can get a wider area of coverage without actually feeling paresthesia, which means you can give a bit more current, which means you can get spread of electric field wider without paresthesia. So paresthesia not being a limiting factor. There's a tendency for better acceptance and better outcomes for back pain with this, purely because you're getting more current in and you're not getting paresthesia that is intrusive for you in the legs, that is limiting your building up of current. But the real daddy on this field became a high frequency. Remember earlier, as I said earlier, we're talking about a 40 hertz frequency here, and these pulses of 500 hertz. And here we're talking about 10,000 kilohertz, 10 kilohertz or 10,000 hertz. So that's the big difference of high frequency spinal cord stimulator. This is another form of paresthesia-free neuromodulation of spinal cord stimulator. Now, what this was, this was one kit that was introduced sometime in the range of 2006, 2007, 2008, and a lot of feasibility studies being done at that particular time. It took a bit of time for it to mature, but it has finally been licensed for use in America in 2015. It was licensed for European use a bit earlier than that. Now, the mechanism of action for this, because it's paresthesia free, you don't get immediate benefit. You need to have accumulate the benefit a little longer, because they're not getting paresthesia. They wouldn't know that the stimulator is on. Some people use the stimulator right through day and night, including sleep times, including driving times. So driving and stimulation, there's no restrictions on it. So it's licensed for to be used during driving. And the theory behind this is basically where different nerves will get, when you're doing such a high frequency stimulation, nerve A and nerve B, or nerve fibril A or nerve fibril B, will get stimulated at slightly different varied intervals depending on their own repolarization and refractory period. So they may get staggered. When they get staggered, then they will not have a cumulative benefit. If at all it is a tonic stimulation like 40 hertz, each time there's a pulse that's happening at 40 hertz, all of these fiber A, B, C, D, E, F, G, all of them are getting stimulated at the same time. Okay. However, if they're staggered, then what you're doing is you're accumulating more and more GABA with each nerve fiber coming at different times and firing at different times at its own individual frequency rate depending on this refractive period. And this means more GABA accumulation and more inhibition of pain. And because of maximum fibers of these tend to be conglomerated around the conus of the spinal cord at the bottom. So T910 is the area where these fibers tend to get concentrated, and then you're getting pain relief for a significant chunk of the lower body pain, neuropathic pain, remember. Okay. So high frequency it became a new technique, initially has some skepticism, but however has shown over time that there's no mapping required. So there's, remember we talked about earlier, electrical field steering, mapping, lead positioning, gutter. No, for this one, T910 level, midline paramedian, 2 leads placed, anchor them, and you're out. So you don't have to map, you don't have to spend long hours time. There's no programming, lots of programming. Leads are in the right place. You just do the stimulation. There's no paresthesia felt. There's no mapping of paresthesia for the target area, and it tends to get its results. Over time, it tends to have shown that it's slightly better pain relief compared. It gets better back coverage. Very similar concept to what the burst stimulation called, but actually improving on that. It's paresthesia free, and this was the Sensor RCT trial that eventually led to its US FDA approval. With convention is compared with the high frequency stimulation with conventional stimulation for back pain and leg pain, and it did show high frequency stimulation basically gave more relief. High frequency stimulation gave more relief of pain scores compared to conventional, and at 12 months the relief was sustained at with improvement in 78% of people compared to 53% in conventional SAS. And at 3 months' time, the figures were slightly similarish. Again, this was only 81%, and this was 49% at 3 months. This is at 12 months. There's lack of paresthesia, so you can sleep, drive. There's a disadvantage though when you're using such high current. When you're using such high current at such a frequency, you need more power, electricity power. That means the battery you need will get exhausted quickly. So your battery size becomes a real problem. And these are rechargeable IPG when it first came on, which means you need to recharge it very often, every 2-3 days, depending on your parameters that you used. Whereas in conventional SCS, you're looking at recharging depending on every once a week, 2 weeks, 3 weeks, sometimes even up to a month, because the current used in that conventional is much, much less than the high frequency constant. And because high frequency paresthesia free, tend to use it 24/7. Other therapy they used intermittently, off at driving times, off at sleeping times, which meant less current use. It means the battery can't last, which means it has to be rechargeable battery for the high frequency systems. This is the evidence base which led on to NICE in 2019 giving us a statement that the evidence base for this particular sensor high frequency stimulation to be for back pain and leg pain. And this is in addition to the original guidance that was published way back in 2008. Going on forward, what happened then was they compared spinal cord stimulation on different waveforms, and this is a systematic review. There are individual studies on this one, and there's one more multi-wave study that is being not yet published, but this protocol was published about 2.5, 3 years ago, where they are doing a head-to-head comparison in the same patient of different stimulation modes. In the same patient, same hardware implanted, using different stimulation modes to see whether conventional stimulation comparing it with burst stimulation in comparing it with high frequency stimulation. Where certainly burst stimulation is superior to tonic stimulation for treating low back pain, and the trend is something similar for high frequency stimulation. On this particular RCT study, this was slightly dated 2 years ago, so the papers were much before that. They did not particularly come up with any strong statement for high frequency stimulation. Certainly burst stimulation better than this one, but it is also demonstrated in subsequent studies where the high frequency stimulation also gives good coverage for back and leg and better outcomes. Then we said electronic technology is also always evolving. So you've got multi-wave programming options. This is a new system by Senza, which is called the Omni, which is basically can do all sorts of combinations of stimulation like conventional, pulsing, burst stimulation, and high frequency stimulation all in one. You can have programs to deliver them at different times in different combinations. Now, one of the things of this dynamic stimulation device that, remember we said with tolerance, with the same stimulation parameters, over time, you found that you develop tolerance to the effect of it, the efficacy goes away. Now, with this varying doses of electricity that can be used in different waveforms at different times, so that tolerance effect can be in no way addressed and dealt with. And these sophisticated systems have come to a stage where now we can do virtual clinics, where earlier you need to be do the programming for the patient, had to come in and you had to place a little receiver on the battery itself, and then the programmer is used to program it, and the program is transmitted across to the battery and programmer. However, with these new systems, a lot of this is done remotely with the industry programmer guy sitting somewhere far away in different part of the country or different country maybe, and they are collaborating through smartphones, iPads, and remote programming being done via internet. So that gives an opportunity for virtual clinic and remote programming. Just coming to the end of the talk, what I'm going to just mention is there's something new that is licensed in the market in neuromodulation for spine, where now they're trying to get rid of the battery. Remember, in the complications for equipment, I said some people don't tolerate the battery. Sometimes the battery can erode through the skin. The battery side pain can be a problem, and some actually people have got expanded say the pain relief is okay, but this is causing more grief now. That brings a slightly different connotations to it. I would wonder then why didn't you select your patients in the first place? If this battery pain causes you so much pain, then your pain in the leg is probably not commensurate. It's not bad. It's just that you're magnifying it. So those conditions come, but certainly just be aware that there are new systems where there's no battery implanted. It's just a receiver in the lead. So on this particular system, that's the receiver, that's the lead. You place that lead on your target area that sits in the subcutaneous tissue. It's all buried, implanted, and then you just place an external transmitter over the receiver. You program it. Stimulation can be started off, and you increase the current. So through the external transmitter, the receiver receives the current, and you're getting target area stimulation. This is going to be a game changer in a way, because the applications suddenly become quite huge, because this lead can be placed in the spine. Yeah, this, I think one slide has gone missing. So I had one more slide which probably got deleted inadvertently, but you can basically place this in the spine like a spinal cord stimulator with this sitting in the cervical plane. This can be placed on suprascapular nerve block for neuropathic shoulder pain after multiple shoulder surgeries. That could be placed on a peripheral nerve in the arm, like say median nerve. After a couple of decompression has happened, but still neuropathic pain because of neural damage for peripheral neuropathies on median nerve or ulnar nerve. So the lead gets placed on the nerve. The receiver can be set in the forearm. They place the transmitter on top of it, use stimulation. Commonly, we also find that with many of the stimulation, once you get a neuromodulation stimulation and a pain relief benefit, there tends to be an outlasting effect for it, for ranging from minutes to hours. Or there are occasions when people will say, I use it for 20 minutes per every morning, and that's it. I don't need it for the rest of the day. So we'll say I use it in the day, nighttime I sleep is a problem. Before going to bed, I use it for 15, 20 minutes, and then I don't have to use it again. So that benefit outlasts the stimulation period, and you can utilize that for the benefit. And this particular kit has also got slightly different lead configuration, where it gets tines, silicone tines on it, which means it just grabs onto the tissue and it stays a bit stable, so it doesn't move and migrate. There are also new developments of anchors where you load an anchor on top of it. That anchor you load it and push it up to deep fascia or ligamental level, and then you deploy it, which just sort of opens and pans out a little bit and gets grip with the tissue around. So it anchors the lead to the area of pain or your target area. That means less migration, and then they don't have anything bulky sitting in their spine. And the key part in all this neuromodulation is MRI compatibility. About a decade and a half, 2 decades ago, a lot of these kits were MRI incompatible, which means you have this implant, you can't have an MRI, full stop. If you get a new symptom diagnosis, suspected cancer, a new spine, cauda equina, you can't have an MRI. So it'll have to be a myelogram CT for ruling out cauda equina. However, over time, the industry has moved on. They have become MRI compatible. A lot of the pacemakers now are MRI compatible. So industry has moved on, and these MRI compatible devices became partially. You can use 1.5 Tesla MRI for head coil only, not the body coil. However, going further now, you got equipment that come with 1.5 and 5 Tesla MRIs. They're compatible. They will give some specifications about the absorption ratio and stuff, very technical details that the industry will coordinate with the MRI center, and they can adjust and undertake MRI scans of different regions. And all this new kit we're talking about, like the Freedom. This is the Freedom kit, which is called Freedom from IPG. Freedom device and the sensor device we're talking about. These are all 3 Tesla MRI compatible devices. So over the last hour and a half, we've talked about neuromodulation, its wide applications, electricity used as a treatment in chronic pain, electricity and neuromodulation. We're trying to restrict it to spinal pain. We discussed conventional spinal cord stimulator and its mechanism of action. We discussed its limitations about the low back and distal extremities coverage and the industry adaptations for that. However, further involvement of high frequency stimulation and dorsal ganglion stimulation like technology has meant there are no more options in the number of people gaining access to neuromodulation as a treatment in comparison to incidence of neuropathic pain in the community generally is quite low, and the uptake is still very low. And the recent paper of data from 2010 to 2020 in the UK said only about 1.5% of neuropathic pain patients actually get the treatment. However, they're doing that is sort of a misnomer, because remember, not all neuropathic patients are bad enough to need treatment, but certainly still the proportion of patients who could benefit from neuromodulation are not made aware of it or not offered it. Of course, we don't have the capacity to deliver it as well, and the cost implications has meant delivering this therapy is reasonably challenging because of funding restraints. How this brings in Freedom neurotransmitter, and this is called StimWave, and this is a game changer. Game changer because the leads are inexpensive. The most expensive part of a spinal cord stimulator kit is the implanted battery. That's the most expensive part. If at all that goes out of the question, then you've got leads and external transmitter, which is not implanted. The expense is much lower. So this means this therapy can be deployed much more widely and appropriately in appropriately trained hands for making sure lead placements are done appropriately with less risk of migration. Because of freedom or stim wave freedom neurostimulators is something that we might see a lot more in the future. There are many of these systems that are a stim wave, a proprietary brand again, which has got stimulation transcutaneously. So you don't have to implant a lead. So there's some means of those. I'm sure you'll see a lot of advertisements on that, usually used by chiropractors, osteopaths. Coming to the final new frontier is the spinal cord stimulation that has resulted in patients walking after spinal cord injury. We know traditionally the spinal cord injury pain neuropathic pain doesn't respond to spinal cord stimulation therapy for pain control. However, on this particular occasion, they have used spinal cord stimulator for improving movement. And this is, again, remember, this is still in lab state. It's still there are about a handful of, that's in single digits, patients who have had this and have had a follow for a year to 2 years with improvement and movement of the legs. The caveat difference there would be that the leads would be much wider. These leads are commonly placed in the roots. Remember, all the time we're talking about lead placement over the dorsal column. In this scenario, you'll be dropping the leads into paravertebral gutters, where the dorsal rootlets and ventral rootlets would be, and that's where you get the electrical stimulation. In conventional spinal cord stimulation, you don't want the leads to fall onto the roots, but over here you would want a deliberate to fall onto the roots for you to get stimulation. So with spinal cord stimulation, it's an excellent therapy. It has to be selected in the right patients with the right attitude, with the right expected results. Otherwise, it will be a failure, because expectations invariably, when you're having something sophisticated implanted, is extremely high for near 100% relief, and then it will be a failure. So if at all is used judiciously, used appropriately, then it's an excellent therapy, and we will see more and more of electricity used as a treatment in chronic pain as we move forward. Thank you for listening, and I'm happy to take questions.
Thank you for this excellent talk, Dr. Hira. If there are any questions, we already are starting to get a few questions. There's a question by Dr. Ramchandran about an accidental dural puncture. What can be done? Do we abort the SCS implantation? And what is the risk of hemorrhagic complications like an SDH?
Obviously, we are doing an epidural, so there is always going to be a risk in the long term. The usual figures that we quoted was anywhere in the range of 1 in 10,000. The risk of hematoma is per se hampering is a problem. Sometimes, if at all, you find that they're a bit more oozy. Sometimes you find that if they're a bit more oozy, then you would notice that what would happen is you got a blood hematoma around the lead. So you're trying to program it afterwards, you find that the impedances are very high and you're not getting paresthesia, or you increase a lot more current, and subsequently into second day, third day, fourth day, you would need to try and reduce the currents down, because now the hematoma is regressing. So that small amount of blood around on the lead itself. Serious hematoma, very low risk. I personally have not come across anyone in the community that I have communicated with all this time. So that risk is extremely low. Dural puncture. Come to the next question. If there's a dural puncture, what do you do? If the dural puncture is at a level different from where the lead placement is, then you can go ahead and do. Some people would do that. My inclination would be to abandon, give it time for probably a few weeks down the line to try and get that reimplanted at that stage. The reason I would do that is because one is infection, meningitis. Second is the needle you're doing is using a large caliber needle, and this dural puncture is likely to give you a headache, and that's going to interfere with your trial. If at all you're doing a trial, It's going to interfere with the assessment of effect of your trial, because now you're focusing more on the headache than your primary pain pathology. If at all you need to go ahead and need to do a blood patch, then if you already got a lead there, it's a problem. Are you introducing infection? Infected lead is disastrous.
Thanks for
Because
answering.
when we talk of infections, most infections tend to be superficial pocket infections and lead tract infections, and a very small proportion happen to be the epidural space infection and collections. But with the SCS lead and dural puncture and epidural blood patch, if required, and infection, then you're looking at epidural infection.
So you'd prefer to be more conservative and not too aggressive in your doing
I would
this.
prefer, and that's what I would do.
The next question is related to a ballpark figure. Can you give the costs of these devices roughly?
Different regions have got different pricing by the industry. The current published pricing in the UK, you're looking at anywhere between a rechargeable, assuming a 2-lead kit, a 2 leads placement, 2 anchors, and implanted rechargeable battery. We are talking about anywhere between 13 to 20,000 pounds, equating to 13 to 20 lakhs approximately. However, I can also see that in the Middle East, the pricing will be slightly different. The company's prices are slightly different in different regions.
So we have a few. Thank you for the excellent talk messages. So again, yes, thank you for the excellent talk. And if is there some way that the students or the delegates can be in touch with you, is there an email that they can reach you at? Is it okay if we can share it in the post?
Yeah.
Post.
So is mutagi.paindoc.
Okay, so you can just share it with us,
Gmail.
and we share it with the
Will
delegates.
do, yeah.
If they have any queries offline, they can follow it up. If we have no more questions, I think it's been a very engaging 1.5 hours actually. Yeah, I hadn't planned on the extension, but yes, so it has been really engaging. I appreciate all that you're doing. Thanks a lot for your help and your vast experience. So it shows when you're talking about it. And I hope that we're able to do more of these procedures. And I hope for a day when the costs of these procedures are affordable so that a lot of patients can get access to this technology. And I also hope that the next
Thank
time,
you, Mahesh.
and I hope that the next time we are better prepared with our PowerPoints.
I know. I used the browser for the Zoom meeting, and then that was a problem. I all shut it down.